Great. Excellent. Welcome. So we're just kind of going around the room and just introducing ourselves and talking a little bit about why you might be interested in this talk.
Well, my name is James Hurst, and I'm from Mountain Creek, Denver, and I'm vice president over there, and I'm also RCB president. I'm just taking up classes and taking notes.
Great.
Give to our LLCs and our boards.
Excellent. So I'm hoping that this is going to be more of a workshop experience for you as opposed to just a lecture-based. So. Oh, no. Oh, that was loud. But more just for everyone's participation. I really do want this to be more participatory. These are my, whoa, that is really loud. I'll try to stay away from there. So describing the issues for helping patients from underserved communities who suffer from chronic pain, understanding the elements of the shared visit model, which it sounds like some of you may or may not have heard about this model for patients with chronic pain, and then to describe experience implementing what a shared visit looks like. And then identifying elements of a shared visit model that may be replicated at other health centers, especially if you, in fact, have an affiliation with one or know individuals at health centers that you think could really benefit from this type of a program. So my plan was to really spend about, maybe 45 minutes of my kind of talking, but feel free to interrupt me at any time and ask me questions. And then I wanted to do more of a small group activity where we, talk a little bit about what the shared medical visit could maybe look like in your community or at your health center. And then finally, kind of come back together and have more discussion about what the shared medical visits can be for chronic pain patients in the future. So like I mentioned, I am the Chief Medical Officer for Sheridan Health Services, which is a nurse-managed, federally qualified community health center. And it's affiliated with the College of Nursing through the University of Colorado. It started out actually around 1997, initially just as a school-based health center, and it was really mostly seeing a pediatric population, and then it had a small adult population, and then grew in around 2010 with a grant from the Affordable Care Act, and we expanded into an adult site, which is actually located at the old Fort Logan campus, which is originally a mental hospital, and was kind of converted into both our clinic and other services, and then there's what's called the ARTS program, or the Addiction Research Treatment Services. So patients who have addiction issues are seen there, and it has an inpatient service there. So we are an integrated care model, and it's multidisciplinary. We include medical providers, which include nurse practitioners and PAs, and MDs. We have RNs who do case management and public health, pharmacy, behavioral health, and dental. And then the Sheridan Community is, I don't like calling it a suburb, but it's basically an adjacent township to Denver, and it's kind of in the south side of Denver. And the population is approximately 18,000, with about a half Latino. And this is kind of a shot of our pediatric clinic, and we because we're tied with the University of Colorado, we do have a lot of students who also rotate through our clinics, and so actually this is a former nurse practitioner student. So kind of our history around chronic pain and what happened. So like I mentioned, in 2010 was really when the adult clinic was open, which we call the community clinic. We technically are able to see pediatric patients there, but mostly it's been adults. And at first, we were not serving patients who did have chronic pain there. I was not present at the time, and there really were no MDs practicing there. So it was really just a nurse practitioner and a PA, and they felt that within their scope of practice, it was not comfortable in the limits to be prescribing chronic pain medications. So they really just saw it as acute pain management and then refer if the patients had chronic pain. And then I kind of came on as a provider in the beginning of 2011. And we definitely have been increasing our volumes because, as you can imagine, we've only really had our doors open for approximately 3 years. So we've been seeing kind of more patients who would come in on chronic pain meds. And so what do you do, and how do you manage patients who have already coming in on a lot of pretty significant opiates and other medications? And so what we were finding was that because I was present and so doing a lot more consulting for the nurse practitioner and the physician assistant at the time, we started managing more patients who had chronic pain. And the problem was that there wasn't enough consistency. Because my practice there is really only about a full day a week, what would happen is that patients would unfortunately have to, see another provider, get a new script from somebody else. It was starting to look like provider shopping, but I think it was more about access and just trying to understand the system. And what would happen is that there'd be poor follow-up, or patients would frequently call the clinic asking for refills, and it was, or just drop into the clinic without appointments. And so it would be disrupting flow, and it would be very hard to then kind of help them and also make sure that we were giving adequate care to the patients who had scheduled appointments. So unfortunately, when we looked at the patients who did have chronic pain, we were finding that they were frequently calling the clinic, that they had multiple other medical issues. Many of them suffered from depression, from anxiety, obesity. They had past histories of substance abuse, or they were at higher risk. Many of them reported either alcohol or methamphetamine use or cocaine. Their lives were a little bit more disorganized, frequently job shifting or losing their jobs. So it's very hard. They had limited resources, and it made it more stressful for them. And frequently what would happen is that their chronic pain would be escalating as well. And so when that would happen is that they would kind of come in for crisis visits, and it was becoming more and more about crisis as opposed to really trying to understand how to manage their chronic pain adequately over the long term. And also what we were noticing is that there's just very high reliance on medications for their management, and the doses were going up and up and up. And what we're seeing is with literature and within the literature and recent studies is that patients who are on very high doses of narcotics have much higher risk for overdose or death. So what we kind of began to implement was trying to kind of create a systematic approach to patients with chronic pain. Number one is what's called the narcotic contract or controlled substance contract. And it's really to kind of, help the patient understand what the systems are within our clinic and how they would, how we would be helping them manage their pain, but also making sure that whatever happened in the future, that they would understand that, for example, if they frequently lost or had, their prescriptions or needed early refills, that they couldn't just call in and they couldn't just expect that they would receive those, because frequently pharmacies won't fill them early, and also we can't assume that they were only lost. In many cases, unfortunately, patients do, or we've been finding that patients were selling narcotics on the streets. And it was becoming more and more problematic because we were then finding that there were a lot of clients who were coming in who were requesting more and more narcotics. So we would also randomly urine tox. So that's a urine toxicology screen. So we would have patients randomly be checking urine to make sure that the narcotics that we were prescribing were actually in the urine. And this was really surprising. We kind of quickly found that there were patients who were using other substances than what we were actually prescribing. And so we were quickly then having to refer them to the addiction program across the street to, really help them, recognize that they had a problem. So in many ways, it was healthy to do these things because we were identifying patients that actually needed more help than what we could give. And then finally, what we also were doing more of is using the prescription drug monitoring program. So I don't know if folks are familiar with this, but in the state of Colorado, and actually in multiple states now, pharmacies are actually tabulating all patients who receive a controlled substance. And they track how many pills were given, what date, and who the prescriber was. And so what you can do then is look at those prescriptions, and you can learn a lot. I'll tell you about a story about a patient who we did this on, and she had been asking for a refill of her Ambien. Now people think, oh, Ambien's just for sleep, and that's not a problem. But actually it can become a medication that you can become very dependent on, and can potentially go into abuse. And she was, by going to multiple providers, and she was actually getting about 300 tablets in the course of 3 months. And we had to really, but by doing that, by looking at that PDMP, we were able to identify that there was a problem. We were able to sit down with her and say, we really need to work on why are you doing this? And it actually turned out that she was using the Ambien for pain control because she wanted to just sleep through the pain. So then we had to kind of shift the conversation. Well, let's try to manage your pain better. But, you can see that if we don't have these kind of methods and, these systems in place, then we wouldn't have necessarily caught, on that, wait, there's an issue and we really need to help this patient. And then finally, it was kind of decided that because a lot of the patient's pain narcotics were kind of going higher and higher, and the levels were becoming more concerning within the scope of practice for the physician assistant and nurse practitioner, that I pretty much am the only one now prescribing all chronic pain medications. So what we also did was we worked within our pharmacy team, and we do a very extensive chronic pain evaluation where it's a full hour, sit down and go through every single medication that the patient has ever been on, any other modalities that they've tried, and really kind of get a sense of, have they been sufficiently worked up for their pain and what needs to be done next. And then finally, the shared medical visit, which is going to be the majority of our discussion today. So what is a shared medical visit? It's also known as a shared medical appointment, and what it is when you have a group of patients who are seen over time regarding a chronic health condition. This can be anywhere from, and many people I think recognize diabetes as being kind of the one that started this kind of mode, but there have been other things that it's spread into prenatal visits, even well child visits can be seeing patients over time. So it doesn't actually just have to be a chronic health problem. It can just be, well visits as well. But for the most part, it started out with chronic problems, so diabetes, high blood pressure, depression even. And then you can be seen by a single provider or a group of providers, and usually they're in kind of an interdisciplinary team. So there are different models of this chronic pain shared medical appointment. SMA is shared medical appointment, just to clarify the acronym. So at Clinica, which is a local federally qualified community health center, they do shared visits for chronic pain patients. Their model is based on a 60-minute appointment, and the patients usually are set up with having a group discussion with a moderator. There is a provider there, so it's really kind of processing within the group. You have a medical visit, and then you have time to discuss maybe some self-management tips. And the behavioral health providers are usually the ones who lead the group, and they also set the curriculum, which kind of is loosely based on this book, Manage Your Pain, Practical and Positive Ways of Adapting to Chronic Pain. And they do it on a monthly basis, so it takes about 6 months for all of the various topics that they kind of have in general outlined to go through. CareOregon is another model, and they are actually, it started in 1996, and they're through Kaiser Permanente. They designed basically a group visit model that would be a series, so almost like a course, and you would take it over the course of about 7 weeks. And the primary care providers wouldn't necessarily be in the visit. It was really just run by usually an RN and or social worker, or usually kind of both. And they developed the curriculum through expert opinion and input from their patients. And they have and this is kind of the curriculum that we've based a lot of our curriculum on. And so what is taught? So kind of the first thing is why chronic pain becomes a chronic problem, the barriers for people to get relief, non-drug related therapies that reduce pain, how do you turn down the intensity of your pain, restoring the body's ability to block the pain messaging, and identifying and eliminating triggers that you might experience, appropriate use of medications, being an effective partner with your primary care provider, and then developing an individualized plan to help manage the patient's pain. And it was a series of 6 weekly group sessions, about 2 hours long each. They were multidisciplinary, and information is presented by physical therapists, pharmacists, physicians, nurses, alternative medicine providers, and social workers. So we kind of decided to do a hybrid. So what we decided was that we felt that this was a good curriculum that all of our patients should benefit from. And so we really our goal is to have all chronic pain patients that we see complete the group visit course. We did it, instead of doing it every week, we were doing it every other week. So, and then we would make sure that we would have the provider, mainly me, actually be present at each of these group visits. So I would be seeing the patients, prescribing medicines, making changes to medications based on what was kind of discussed on at the topic at the course. And we would meet every 2 weeks. And the idea is that after the course was complete, then we would switch into what we call a maintenance phase. So then that group would kind of stay together and then meet on a monthly basis. So, we really have just recently implemented this. So we started planning approximately in late December, January to do this. And we really wanted to make sure that it included every discipline from our clinic. So we had behavioral health, who was the lead in organizing it. We have an RN who really has a holistic approach to care, and she has significant training in what's called healing touch, meditation, and uses yoga. Pharmacy, and myself, and then collaboration with the arts program, which again is a program that's pretty much across the street, and we see quite a few of their clients.
What is that program about?
So it's called Addiction Research Treatment Services. It mainly houses patients who are incarcerated for drug-related charges, and they go through the addiction program there as part of an inpatient. They then kind of graduate on to, as they progress to an outpatient setting. And so we have, it houses men, women.
Is that Pure One?
Yes.
Okay.
Yes.
I want them to get my credits for
So, any other questions before I continue? So we also had to identify a space for a large group. This really does require, a good amount of space, because our idea is that we don't just sit there, we actually do some movement during the group visits. Identifying time that would work for both the providers and the clients. It's not good to do a chronic pain group visit or first thing in the morning at 8 a.m. It doesn't work. Most patients who have chronic pain wake up, they're in severe pain at that time, and so it's very hard for them to kind of get mobile. So usually the goal is kind of, either very late morning or afternoon hours. And then we met probably every other week for almost 3 months in planning this, and I had to identify patients to recruit, and we recruited 6 clients for our first session. So the initial attendance, so we had 5 participants, 2 who kind of came about a half an hour into the start of it, which made it a little bit harder to kind of make sure that the cohort bonded and understood all the rules. We had to have 1 client join at the second session. And then during that first session, we really kind of wanted to lay out with everyone in terms of what their hopes and expectations were, and how they wanted to respect each other, in terms of making sure people were on time to the appointments, confidentiality, what kind of said in the room stays in the room, and then participation during the visit. If you didn't feel like participating that day, that's fine. You don't have, it's not mandatory that you speak at every session, although participation was greatly encouraged. Yes?
What was your criteria to choose participants?
At the time, it really was if, in fact, they were, diagnosed with a chronic pain issue, and if they were on narcotics for greater than 6 months. But some of our clients had not even been on any narcotics to start off with the chronic pain group. But we definitely were looking at that subset in particular, because if their chronic pain had escalated to requiring narcotics, then we needed to make sure that they were included. But yes, opiates were not the only reason. And I'm using narcotic and opiate kind of interchangeably, but that is, so usually what I mean by narcotic, I mean by an opiate-based medication. So this was our curriculum. So first we met and had, again, introductions where everybody kind of got to go around and talk about themselves and what their pain experience has been like. And then we talked a bit about chronic pain and what the definition of that was, turning down the intensity of the pain messaging with physical therapy, being an effective partner in your care, is kind of led by the physician, myself, using medications. We had our pharmacist kind of lead that group, and identifying and eliminating triggers, using more of the holistic approach to care, restoring and increasing the body's ability to block pain messaging, and which was more behavioral health, and developing a personal plan, which is kind of setting up individual sessions with each client. So in your handout that's at the back, if you haven't received one, it's right at the end of these tables. I just have a few of the handouts that either patients had received, and then an example of the curriculum. Again, this was freely borrowed from CareOregon, which we found was a really kind of well laid out, extensive curriculum to use for this approach. And we had asked them, of course, for their approval before utilizing it. But, one of the things was they had an extensive kind of baseline patient questionnaire that they had to complete. They would do weekly homework assignments kind of based on the activities that we did during the day at the workshop. And mainly it was kind of really trying to incorporate some of the methods that we were using or teaching our patients to see if, how they incorporated it into their daily lives. Tips on managing chronic pain, And then stretching and meditation breaks would happen throughout, mainly led by both our behavioral health specialists and our RN. We did not do the full 2 hours. We tried to condense it into about 90 minutes, and that way that I could actually see the clients, in particular those who kind of needed to see me for individual one-on-one. And then we just finished our first shared group visit the last week of May, and now we're setting up the one-on-one individual sessions. Okay. So some of our outcomes, again, these are very preliminary because, as you can imagine, we really just completed our first time doing this. But we definitely noted that the clients talked about them understanding the definition of chronic pain and what it really means, and how that kind of impacts their other parts of their lives. Understanding different modalities of how to treat chronic pain, and what I mean by that, from acupuncture to ultrasound therapy, physical therapy, aqua therapy, starting to really try to incorporate practicing deep breathing, acupressure, healing touch. Clients would actually bring in instruments that they had from their maybe previous experience to show how they use that to manage their pain. It was very helpful to have like kind of the group dynamic where it wasn't just us teaching them, it was themselves teaching each other. And I think that that's kind of the key to a successful shared medical visit, is when the group process occurs and the clients really can talk freely about what's worked for them, what hasn't. And what I definitely noticed was that there was a significant increase in interest in doing other modalities. So many clients had tried physical therapy before, but when they learned about some of the treatment options within physical therapy that they had never experienced, and they had a renewed interest in it. So unfortunately, when you go see a physical therapist, it's not always the same treatment plan for every client. So. And it kind of depends also on the site that you refer the client to. So some clients had very different experiences than others. And so learning about that was very helpful. And also helpful to me, because then I would be more explicit in my prescriptions for a referral to a physical therapist. I would include, recommendations for using things like aqua therapy, or what's called the TENS unit, which is kind of electrical stimulation to try to help control pain. And so, these are kind of, again, we have a very small group, so only 6 clients, and about one patient, she initially had considered starting to use an opiate for her chronic pain, but when she learned a little bit more about the effects of opiates from the pharmacist, she realized that she did not want to go down that route. And when she had learned more about other kind of non-opiate treatments, she said, I prefer never to start an opiate, and had really done a really successful job of managing pain with some of the other non-narcotic pharmaceuticals or medications. And 2 patients who were using short-acting narcotics, or opiates, they now wanted to use what are called the long-acting opiates. And then there was a significant increase among all 6 patients to using the non-opiate-based therapies. So some of our other kind of indicators, I guess you would say, is how many have to go to an emergency room to kind of manage their pain. And during the course of that 2.5-month period, we had about 2 clients who went to the ER who had suffered, kind of an acute on chronic pain episode. And one client decided to discontinue OxyContin altogether. She actually, based on kind of, I think, in part, our shared medical visits, learning more about the medications, and she just decided that she saw red flags within herself, and was concerned that maybe she was going down an addiction pathway, and she tossed all of her OxyContin down the toilet and came in to see me and said, I want to go into rehab and start methadone. And it was a very, kind of significant realization about what was going on with her. I still think she has kind of chronic pain, so it's not that it was all true addiction, but just starting to have that conversation and especially having the ARTS program available to us and being a part of the shared medical visit, I think really helped to keep that discussion a part of the group visit. And then finally, another patient is currently weaning off some opiates, mainly, recognizing that she wants to also try alternative therapies to her pain. So our attendance was, in some cases, spotty. We had 3 of the 6 clients missed 2 or more sessions. There was significant lateness to a lot of the visits, and what happens is when you have late clients to visit, these group visits, it changes the dynamic, unfortunately, kind of midstream, and it makes it a little harder to make sure that the cohort is all together and really is participating. 2 clients required kind of more one-on-one sessions during one of the shared visits, so they actually missed the final group visit. And in some ways, when we kind of reflected on this, we kind of realized that when you have kind of groups together, they kind of go through this kind of cycle of process. And I think we had kind of the part of the breakdown part, but I'm thinking that hopefully when we start to finalize their individual plans and start up the group maintenance phase when they would come every month, that we can kind of reconnect a lot of these clients together. So kind of how the providers and staff felt about it. We definitely felt that it improved our communication for integrated care for chronic pain patients. And what we noticed is that it made it easier for our behavioral health provider to come in with myself to see patients, just together. We don't just see them individually. We just kind of go straight in, and it's huge because it really kind of shows the patient, I think, too, that we really all care for them, and we really want to make sure that we provide them as many wraparound services as we can. But we definitely need to kind of hone some more of the ground rules for the group visits, because when clients miss too many, unfortunately then they lose a lot of the experience of the group, getting to know each other, kind of developing that cohort, and also the knowledge that we're kind of discussing. I mean, the one client that missed several group visits, whenever that patient would come in and start to have a conversation with me, I would say, it's too bad you missed the last group visit because we just talked about this exact issue, and if you'd been there, you would have known. So those kind of elements are really important. But what I did notice that even with the CareOregon group, that they did see that 19 clients would be signed up for the group visit and only 7 would show. So they also had some low attendance rates. And when I say care and feeding for patients, what I mean is really kind of understanding that especially patients who suffer from chronic pain, because it can be very debilitating and they suffer, with it every single day of their lives, and it affects every aspect of their lives, from their relationships with their relatives or friends, their ability to do, the just simple activities in daily life. They really do need more and more attention. And so I've really tried to implement, regular visits with a lot of them, not to punish them, but more just to make sure that we're on top of their chronic pain, understanding, are there other things that we're missing to try to treat. And then also remember provider wellness. What we found within ourselves was that patients with chronic pain, they suffer a great deal, and they talk about it. When we have these group visits there, that they express this a lot, and they were very verbal about it. And it's also to make sure that we as providers recognize that we need to take care of ourselves too, so that we're able to kind of better sustain ourselves and provide good quality care to the patients. So my thoughts were to kind of break into smaller groups, maybe groups of 3 to 4, and kind of ask these kind of questions within the group to see, where you are, maybe in your site, in terms of developing the shared medical appointments or visits for chronic pain. So maybe this group here, and then if this group wouldn't mind moving down here, and then the back group, that would be great. I'm going to turn this off. Am I allowed to turn this off?
Turn around.
Am I allowed to turn it off? Is it just this button? Can you hear me? Oh, there we go. So I kind of, I don't know if anybody wanted to give any feedback of what you all discussed in your small groups about, the concept of having a shared medical visit for chronic pain.
Our group decided that it would be a benefit, at least some modification, maybe based on our different clinical atmospheres, and have some ideas maybe to take back to our home base to maybe encourage.
Anything you want to share specifically?
I do have a bigger, larger sister site personally. I don't know what the group would say to take this information back to them and see if I can work with, also affiliated with my college, UTSU, maybe some pharmaceutical students or something to maybe at least maybe a pain management mental group for patients once a month or something like that. And maybe sprout from there.
Mm-hmm.
It's always a financial issue. That's an issue too. So we get volunteer my time.
Well, just so you know, I bill for these visits.
So you have those on.
Yeah. Mm-hmm. These are all billable. Yes. So you just can do for Medicaid, it's 99214. Mm-hmm. Because you're seeing everybody, and technically you're participating in the visit, so it's an extended visit. So they're all billable. So it's a really good model to actually see a lot of patients, for a similar problem in a shorter period of time.
Do you use the more like a pain education code or something?
No, I just do the chronic pain code. Mm-hmm. It's not just educational because, I do, in fact, kind of see those clients one-on-one, and for most of them, I'm actually renewing meds, too.
So you do that all
Mm-hmm. Oh, yes. So it's huge to tie the two together.
This was rather unique because we had all consumers here or representatives of consumers.
Right.
And bottom line is nobody would want to go to a shared visit. They really these three people felt very strongly that they want to have one-on-one contact.
Oh, okay.
They want an individualized approach to their care. They don't. There was almost stigma involved in being in a group and talking about my chronic pain and my need for medication, almost as if you were an addict. So it was an interesting perception from the consumer side.
Okay. You had some, because I feel like I had two consumer, did you want to talk, Peggy, about your thoughts on it from our group?
Well, my thoughts on it is that my medical needs are taken care of by my primary physician at Tufts Medical Center, and it's not like a local health center. It's I make a doctor's appointment, and then we talk about what's going on with me, and if I need a specialist, she gets me to that specialist, and they communicate, and they talk about what's going on with me. It even goes so far as we have high blood pressure, and sometimes it's hard to manage. And then, I said, well, I'm compliant, but sometimes I'm not compliant. She has a discussion with the pharmacist to see how many times my prescription has been refilled. She says, and asks me how many I've had. I have at home. So I have quite a few. Yeah, I take the So it's that kind of concern I have with her, but I do think that this model could work for me in some instance because it's like, you can see like a support group. And I'm 4.5 years surviving breast cancer. And at the time, my primary was communicating with my oncologist, and they just knew all the ups and downs I was doing, my anxiety and all that. But I think I didn't have a support group. And I think that sort of put me in a black mood sometimes. And that part of it, I think, would be very helpful to somebody if they could be in that situation. That the support part would be good because I just want to know about we're having the medication. But my real visit would like to be when I'm on, or it's not.
Did you feel like the patients learned things from each other?
Mm-hmm. I did. I think one of the things that was most interesting was how the patients would really they would see this as a support group, that all of a sudden they realize, oh, I am not the only one suffering with chronic pain. There are other people who have this problem, and I'm not alone. And that was the big benefit for patients to come back and want to re-engage and be a part of it. And then they would talk about, oh, this worked for me, oh, that didn't work for me at all, and so they would share their stories, and it was very helpful. And because of some of those discussions, and they would, the patients would then, on our one-on-one sessions, would say, can I try that? Or, I'd like to do that modality. And I said, of course, let's do it. So it was really very positive, because I think it kind of it gave more information to the patients about what the options were. It allowed people to really kind of freely discuss, the suffering that they go through on a regular basis and how they deal with it, and support each other through that. And then also to kind of think about other ways to manage pain and see each other, through that. Yes.
I think our group was kind of amenable to the group therapy for a couple of reasons. One, like you said, it's a shared experience there. Two, by having a facilitator of some sort leading the group, they can act as an intermediary with physicians, so they can do the translation, as it were, and plus, if the physician that is involved in it, they do have an interest in pain management to begin with, which has been kind of lacking in the medical profession. Pain management has been often shadows, sort of.
That's true. That's a very good point. So I don't know if anyone from the back group, since it sounds like there was a lot of feeling of not wanting to be a part of that, if maybe you wanted to express your thoughts on it.
Yeah, I would just prefer an individual approach. It strikes me as like almost like a psychology type thing, and I just prefer to go to my doctor for my personal health care. If I had a choice between no care and group care, I would choose group care. But if I had a choice, I would not participate in groups. And I've had 3 situations where I suffered pain for years. Each time I had 2 ruptured discs in my neck. I went through physical therapy, steroid injections, chiropractic care, and I did those things over 4 years. And when I had surgery, after I got from the surgery, I was pain-free for the first time in 4 years. So I'm kind of concerned about pain management. I'm like, what if you can fix me? Don't you want to do that first? And unfortunately, my experience on all 3 occasions, I had torn cartilage in my knees, I had torn ankle ligament, and the very, very nice thing that was ever offered to me in all 3 situations was after years of suffering, and then they went in and they fixed it, and I was fine every time. And I'm like, okay, in all 3 instances, we're talking 12 years of pain that was fixed instantly.
Yeah.
And so I'm concerned about managing pain, especially if there is an answer to fix it, so you don't have it.
Anyone else? Oh, no, please. I didn't realize you were continuing. I'm so sorry. I didn't mean to interrupt.
It scares me to think of putting people in situations to manage something that they might be able to get corrected. And I would like to see people know their options all the way around.
Sure. And it's by many instances that was one of the issues, is to talk about, how can what are the other, treatment options, making sure that, all the proper referrals were made if they needed to see a specialist, making sure all those things were in place, so that, in fact, if they did need, surgery, that was available. It didn't mean that those weren't off the table. It's just more of, if in fact they had gone down those, the usual routes, and this was, unfortunately, like their last option.
Yeah.
Yeah.
I like to say, a person is in pain. I don't think they would want to just sit around. I think they want to care for it. When you sit there talking, oh, I hurt right here, me too. And like this, you ran around, but hey, you still hurt. But then there's the option, hey, you go get the surgery, this might stop the pain.
Yeah.
I don't think you can control pain. Pain is pain, no matter what. When it comes, it comes. You just can't stop it. You might give a drug or something to relax it. You're not stopping it. It's going to hurt. Talking is not going to stop it. I'm telling you, so I'm not too far for that. I'm ready to go find someone, help it now. If it's something they think they're going to do wrong, I think they're going to do wrong to me. It's something to do with pain. Like I say, pain is pain. It's something you're going to deal with. And it's always going to come. But you have the pain, and I have the pain. And you talking about the pain that you have, and I know what you're talking about that. Kathy talked about what happened after all this pain, what cures the pain. It might give you the incentive to ask the doctor, is there a way that you could do something to relieve me of the pain instead of just relieve me permanently of the pain instead of just once a week or twice a week or once a month. If I could get rid of it, it's just so we can do something. But you wouldn't know unless you heard from her that they did this surgery and it was successful. So sometimes, I'm going to say, we all have private good people at some point in our life. But sometimes, in order to get the result that you need, I can understand what you're saying. Yeah, I have to talk. No, I understand what you're saying. That's why I just wanted to put that introduction there. So people could think about it. Well, that's how you find out things. Yeah. Well, I talked to her, she had the same thing. Right. That's what I was saying. Like, you're in the group and we're talking about things. But I also said, you still hurt. It does. It does. It does. So you can talk about, well, what happened here? Well, like I said, this happened like this, and I waited so long, and I went to the doctor. Oh, yeah, okay, good, I did. I think I'll do that. But where I'm really getting at the pain, you're not going to get rid of it. And that's just it. Pain is pain.
Yes.
I wanted to comment on the group discussion. Sometimes in our normal day life, in our family or our people around, I know sometimes April might see me a couple of days in a row, so I'm just in pain, She don't want to hear it, This is just an example. But, she don't want to hear it. And then, when you're around your family members, sometimes you can't express your pain. And when you say, oh, I'm in so much pain, and then when you go to these group discussions, you can go to a group discussion and talk about it and not be judged. Because especially like with back problems and desks and stuff like that, if it's not visual, people have a tendency not to believe it.
They don't see it. It's not there.
So I personally like the group discussion.
Yeah. And, I totally respect, what you were saying, that the experience that you've had, that you've, once you had your surgery, you were completely cured of your pain. And I'm so thrilled for you, because I have seen many patients who've had the surgery and they're worse, and that they wish they never had it. And now they're suffering in more pain, and they don't have any other options because they did the surgery and that was it. And so now it's about managing pain. And that's really where the shared visits come in, to try to create that support network, to try to build that kind of camaraderie. Patients with a disease called fibromyalgia, chronic issue, won't go away. You can manage it, But there are going to be good days, and then there are going to be bad days. Arthritis, a huge cause of chronic pain. Not every patient is going to be is not going to be a candidate for surgery. So they also have to live with that pain. There are the good days and the bad days. And how do you work through those, and how do you make more good days than bad days? And how do you, find out about other possible treatment options? And, I think that there is, I call it kind of the therapeutic relationship. Sometimes when I see patients just one-on-one, just talking, about what they're suffering through helps them, and it kind of lightens the load. But to even share it with other individuals who are suffering the same way they are, it's kind of a further boost, to feeling like, oh, wow, I'm not alone in this.
I like the team concept because it seems like the pain people it makes them anxious and more depressed, and then that creates more pain. It just exacerbates the pain. So it seems like we need to deal with that too, to release the anxiety, depression.
Yes. Right, and that's partly why we have the behavioral health specialist there, talking about, the fact that so often, when you suffer from chronic pain, patients do develop depression or anxiety. They're fearful that when is the next, episode, going to hit, or how am I going to be able to go to the baseball game with my kids? That that was one of the dreams of one of my patients, is that she could walk, from the parking lot into the stadium and not suffer with pain, because she wanted to be there with her kids at the baseball game. That's her dream.
Isn't that a mind control thing?
Well, that's one of the things that we talked about in the group visits, is how to reduce kind of your pain through, things like meditation, breathing, trying to decrease the pain stimuli, and doing those same things. But you have to practice them, and you have to learn them too. It's not instinctual necessarily.
I was thinking, because you said, you talk about it, and then like this lady here said to someone else, you talk about your pain, and then all of a sudden you get anxiety. There's another situation about that. Well, I was doing this and I have anxiety. Now, how can I help myself with anxiety? You feel really depressed, and then you see another doctor and all this. So.
We don't necessarily have to see another provider. It's just that when you have the team approach, then you have everybody together on the same page. So you don't have to, go to a new place.
So what I'm saying is to each his own. That's what I'm trying to.
Oh, sure. Absolutely. No, I understand that concept too. Great. Well, does anyone else have any other thoughts? One of the kind of the big issues today, at least in Colorado, is marijuana legalization, and whether that's going to be kind of the.
I think that people abuse it. People, just like any other drug, people, where it helps some people.
It has become a joke, the marijuana legalization. Everybody in their brother has a med card for medical marijuana. Oh, I'm in chronic pain. Kid, you're 18 years old.
So you're saying that it's
because I have very, very bad. I have the fibromyalgia. Yeah, and I have my sciatic nerve is pinched, and I have bulging discs in my back and spine. And I was at one time on 22 different meds, and the meds were making me sick. I was getting sick from the meds and things like that. So I started smoking marijuana and replaced it for some of the pills. But now people have abused that just like any other drug. So it's hard for us to, just like with our narcotics, it's hard for us to get, it's hard for me to get a prescription for a narcotic to help me get through the day or whatever, because now that's the number one drug on the market now. It's gone from crack, cocaine, and things like this, substance abuse drugs, to prescription drugs. And, and I really believe that marijuana can be used in different ways as far as, my grandfather, he used to put alcohol with marijuana and plants and different herbs and stuff, and that's what his remedy was for, like, a cream for arthritis or a cream. That's what they used in them days. They believed in it. And, that was medicine to them. But because of the abuse in our society, it's hard to get any kind of comfort from this.
Mm-hmm.
When Colorado has implemented the marijuana legalization, it has virtually become a joke, and they're also not looking at the long-term effects. Heavy usage has been associated with so many other problems. It can eventually cause more problems.
Mm-hmm.
Cancer rates are higher, with long-term heavy usage, psychosis, sexual dysfunctions.
Mm-hmm.
So but they're not going to know that for another 10 years.
Yeah.
All of a sudden, boom.
But then again, that's caused from abusing a drug.
Mm-hmm.
If you maintain how you're supposed to take a drug or do a drug, then it should help you to a certain extent.
Mm-hmm.
But if you abuse it, that's what's going to happen.
Yeah. Mm-hmm. Well, that's what they're doing. Kids 18, 19, 20 years old, gives them med cards.
Any other thoughts about that issue? Well,
Like everything else, everything that God put on this earth, He said, is for the healing and the feeding of the nation. But like everything else, when you overdo it, it becomes wrong. If you overeat, you're a glutton. If you overtalk, you're a gossip. If you overdrink, you're a drunkard. So what are we going to do?
Mm-hmm.
What are we going to do? Going to just stop doing everything because some people we overabuse the social services that we have here. Are they going to cut all the social services because some people abuse it?
Right.
It's like education.
Right.
And we, as the older ones, we have to educate our children. We have to sit down and talk with them. Let them know that there is no wrong question. Every question is a right question. And you as a parent should be able to talk to your children and tell them X, Y, Z. And if we do it at home, the less the law will have to intervene. But I tell my grandchildren, I have 5 children. I have 6 grandchildren. And in my 5 children, not one day the police have to come to my door. Not one day my mother has 11 children. Not one day the police ever had to come to my mother's house and ask for anyone. Because she instilled in us respect. Respect for yourself, respect for others. And if you respect yourself, you'll be able to respect others. And I tell them, I told a police officer in Boston, they know something. In my opinion, when a child gets into trouble, they should not arrest that child. They should go and hold the parent. Because he or she is responsible for not bringing out that child. I am not saying that children will not do